Bueno, después de esta impresionante charla, vamos a presentar al profesor Gerard Giordano, que también es una referencia en cirugía de revisión séptica y a su vez con navegación. Muchas gracias.
So good morning, everybody. I can see that I share the same complex cases than my colleagues, but I present you my experience of knee revision with the use of navigations. Is not for my worst cases. There is some limits, of course, depending of the limits of the component, the CCK component. So I come from Toulouse, France. I stay in the university hospital 9 years, and now I'm the integrate in 2007 the Joseph Ducoin Hospital in the center of Toulouse, and I'm the chief of the trauma and orthopedic unit. I perform a lot of revision, around 130, 160 per year. And I'm just present you this experience. It's 20% of my knee revisions. Since 20 years now, I'm always aimed to simplify and standardize revision. So I set out to move in this direction based on three approach to development: strategies, technological supports, and surgical techniques that could be put in place to achieve this goal. The integration of navigation to manage knee prosthetic revision over the last 12 years is part of this approach. It's really a chance for me to share with you this experience, and I would like to thank Antonio Jose to this invitation. It's always a pleasure to come in Spain. Conflict of interest. I'm a designer of the GPS system I use for this presentation and for this navigation. So, when I started using navigation, it was to learn more and use it for my knee revision. And after 2 years of practice, in 2012, I started implementing Optetrax CC use with the GPS system. In 2010, after 8 years, 25% of my navigation were for revisions, which represent over 300 surgeries. And for me, complex revision in this presentation are periprosthetic infection. So 70% for periprosthetic infection treated in one stage, and I confirm you, I use one stage since more than 15 years, and I think really that it's a good way. Of course, we don't have to be dogmatic. There is limits, but one stage is probably the good way to do, and a secure one, a safest one for the patient. I repeat, the aim is to standardize and simplify these complex procedures. We know that TKA revision will increase over the next 2 decades and by a large proportion. The main causes are well known: aseptic loosening, instabilities, infection, patellar revision, and in my opinion and experience, an underestimate reason, metal allergies and hypersensibility, and I think there is a link between infection and indirect link between infection and allergy in some cases. So we try to have a view about this hypothesis in the next few years. To give you an idea of my daily practice, half my revisions are due to infection, 20 to aseptic loosening, and allergy probably accounts for around 10% actually. The use of navigation in revision is, for me, quite the same things for aseptic and septic surgeries. As this video shows, sorry for the song, the clinical results are virtually equivalent. We talk about this in more details later in my presentation. Few words about the GPS system that I've been using for 12 years. It's very ergonomic with an interface designed to be intuitive and easy to use. The instrument set is simple. The trackers are active, which eliminates reconnection difficulties, and above all, we can determine the different stage of the operative procedures before surgeries, define profile, specific profile, so that it is as close as possible to what we could do without navigation. I have 4 different profiles, 2 for navigations, one with gap balancing or kinematic, and the second with independent cuts. And in 2014, we reported this work on 3 sites with 3 surgeons practicing differently with the system. This study demonstrates the precision of the system despite the type of profile, the techniques, and the surgeon for primary surgery. That it was, for me, the key point to switch and go ahead with this system to perform revision. What revision can do for knee revision? For navigation, sorry. Firstly, it provides a real-time analysis of the primary implantation in real time after reference point acquisitions. In certain cases, this enables us to better identify the causes of implantation failures on the mechanical side, of course. It helps us to optimize the joint reconstruction. But it must always be cross-referenced with analysis of pre-operative X-rays, ligament testing before incision, and intra-operative findings. So it's a tool, and only a tool. We need really to cross with observation intra-operatively. Navigation is only a precision tool that helps decision-making and execution. In the first stage, I used the system as the primary surgery with an independent cut profile. The initial objectives were to test the system in this configuration and secure the management of the point acquisitions on the primary revised prosthesis, R1, not revision at the beginning, to evaluate the quality of the resections and to validate the cuts, axes, slopes between the plane parameters and those validate after cutting and testing. And it worked well. Sorry. So I repeat, I always keep in mind that navigation, it's only a precision tool. Its information must always cross with the 3 points I report you. In practice, the basics of my surgical procedure are relatively standardized now. I use no tourniquet, no drainage, even for septic revisions. Navigation is used with Exatec CC Optetrac implants, and probably it's the limit of the combo. Not probably, it's the limit of the combo. I integrated a kinematics test over the entry amplitude arc into my profile, enabling acquisition before explantation of contents and validation for the reconstruction with trials and definitive implants. This patient had both a chronic laxity complicated by an acute polyethylene dislocation, and a periprosthetic infection, so mechanical and infection causes of the revision. The management of intraoperative bone loss after component removal is one of the key points of these revisions. The radiological classifications can help the surgeon to anticipate the preoperative condition, but have limits. This point is difficult to predict through preoperative planning, particularly when treating periprosthetic infection, which generate additional bone defects because of the bone explantation and the debridement of the bone too. So, otherwise, I think as Migaud, our French leader, that known classification is reproducible, of course. Use the more simple one with a precise lesion description. For the operative report, for me, the ARI one. Navigation helps us to optimize bone resection adjustment in real time, even for asymmetrical medial and lateral bone defects. You can adjust your planning. If we have a video after this presentation, I can show you. And you can just adjust your planning, both lateral and medial, and manage separatively your medial and lateral resection, both for femoral and tibial side. And you have a perfect knowledge of the level of your resection, so you can manage correctly the augment used. Guided resections are more precise and more economical too, which is important for prosthetic reconstruction because I try to avoid, if it's possible, in these cases, slides, cones, and try to use only augments, usual classic augments, and some cases you're going to see associated with allograft. By a precise knowledge of the bone resections, the use of augments is optimizing. An example of the management of the tibial osteoitis requiring a 20 millimeters asymmetrical medial resection to debride the infection with the use of 11 millimeter augments supplemented by an allograft augment with a good integration. You have a perfect knowledge of your resection, so you can manage this type of reconstruction. This one-stage surgery was performed 9 years ago, and the patient is still working. This femoral bone loss is a question. As you can see, we have with radiologic analysis, difficulties to determine correctly the quality of the condyle, particularly in these infected cases. And it's a question for the CCK implant use in this case, with a maximum femoral augment of 10 millimeters distally. Precise information and the same time of combination of metal and bone augmentation in the distal femoral allowed this 10 years old reconstruction to take place. In 2014, I tried just to analyze my change of component use. And I just show you that navigation has also enabled me to modify my use of the various revision implants by increasing the proportion of CCK use in comparison with hinge prosthesis. You can see that the curves cross when navigating surgery was introduced. Another contribution, alignment management. So it's a great question, alignment actually for primary surgery. I consider that for revision, I stay around a mechanical alignment. I think an adjusted mechanical alignment with a a variation of less 3 degrees on the T-bar side is probably the best option, the safest option, to be sure that we can ensure the quality of the anchorage and avoid specific complication with stems, I mean stress shielding. So, what is important to understand is that you change with navigation your classical way of thinking with a conventional ancilla, because you can switch and use navigation as a primary surgery by the second option I show you. I mean an epiphyseal-metaphyseal reconstruction, resection, and after you make a deal with the stem position by switching with the conventional ancillary. And we know for the primary surgery, the literature shows the contribution of navigation to the precision and reproducibility of lower limb axis adjustment. And in my experience, it's true independently of the type of alignment used, even if the study reports results for mechanical alignment. For primary, but we have validated this on a study conducted on the first 44 patients with navigation for periprosthetic infection. For revision, I use most of the time, I explain you, an adjusted mechanical alignment. So navigation is probably a good way to mastering correctly the alignment and limited the outliers. Another very big advantage for me, but probably less report, is the ability to simulate the various reconstruction parameters prior to bone resection. So navigation is probably a good tool for simulation, intraoperative simulation of option. For example, what happens to the gap inflection if I vary the size of the femur, or if I had of femoral flexion, or if we vary femoral offset, or all three in the same time. So you can really choose the workflow and have on real time before cutting, choose the best option with 3 immediate simulations. And to obtain even more information in recent years, I have been performing some of this navigation, particularly in cases of significant laxity or axis default, with a gap balancing. It's not used with a tensor, but I use a kinematic pre-explantation and after to validate with trials and definitive implants and compare the quality of the laxity management. The clinical results live up to my expectations with rapid recoveries close to those of the primary prosthesis at 1 month and a half. And I can show this video, but it's really, I'm sorry. So, just to show you, there is no real difficulties for several patients. It's really interesting to see that it's reproducible. And if we analyze the Oxford scores and compare the group of aseptic revision performing with navigation and septic revision performing with the same system in one stage, we can see that we have quasi the same results and quasi the same recovery after 1 month and a half, after 6 months, after 1 year. So you have no real difference, as I explained you at the beginning of my presentation, between aseptic and septic revision using navigation. The average John Thrum are good, And these good results are reproducible even for revision of revision. So I have some cases of revision. Most of the time, these rooms are obtained in the 2 first post-operative months. So it's really important because we can consider that these clinical and radiological results are highly reproducible, and now with an average follow-up of about 7 years, 12 years for my oldest cases. I say you that 70% of these revisions are performed for periprosthetic infections, and in terms of strategy, without being dogmatic, the single stage remains me a priori strategy for the past 17 years. Two stage feeds on the impossibility of one stage. And this slide summarizes our current criteria to define the limits of the one-stage procedures. Fungal infection are the only frequent indication for 2 stages. The surgical no-go is intraoperative and concerns the limit of bone reconstruction after implant removal and bone debridement. And in the knee, the indication for a flap and the presence of a stimulus tract are no limiting criteria for one stage. So there is really a large place for one stage revision, but in fact, if you think about a flap, do it. If you think about a flap indication, do it, because most of the time you have a complication, a severe infection. So after 10 years of practice and over 300 revision navigation, I have reported no specific complication due to the tool. And I can confirm that the CC Optetrack and GPS combo is efficient and safe for revision 1, revision 2. Apply in 1 stages for periprosthetic infections. The treatment of the infection and functional results lived to my expectation. Another key point is significant medical economical impacts with improvements in operating and hospital times, blood loss, and an increase in the number of patients able to return at home. And which now leads us to initiate a multicentric study in France on the possibility of improved rehabilitation, fast rehabilitation in septic revision. In 2014, we go one step further with a decision to elaborate a dedicated RTK software. The goal was to obtain an accurate revision management by mastering the bone resection, the augments, it's a new step, the kinematic and the stems offset with a new interface. But this soft exists, but is too far ahead of its time. So we can't use in Europe because it's associated with a CC logic component with CON and augments. And we need to obtain the agreement of European Union. Few examples. I showed you this X-ray and laxity with periodic dislocation. With this post-op X-ray and pre- and post-kinematic screens, with a rapid post-operative recovery. So this patient goes well actually after 7 years. This situation of femoral distal bone loss raises questions about the CK implant. I show you, and with the means to respond to preoperative findings, metallosis, bone loss more than 50 millimeters, so it's more than the 10 millimeters augments, patellar loosening and central cavitary epiphyseal tibial bone loss. And we use distal bone allograft to reconstruct with metallic augments the femoral side, distal side, with good results too. You can see for these infected cases the revision. So, of course, the navigation has some limits. These limits are the implants, and the future contribution of cone and new augments for this CC logic is probably permits you to go far away. So I use this combo for, as I said you, first revision, second revision, stay possible, but you need to have a B plan, perioperative B plan with an inch prosthesis, and it's more difficult after 3 revisions with massive prosthesis and inch prosthesis. So in conclusion, navigation makes it possible to simplify and improve the quality of knee reconstructions while combining medico-economic advantages, in particular by helping to advance the idea of easier rehabilitation for revisions. And the one-stage management of septic knees revision using navigation is reliable and effective method that has helped me progress in performing these complex surgeries. I think we can think about the next step with IE integration with navigation. So actually we have all the, it's a French man speaking about reset, you know, and gastronomic resets, but we are all the ingredient, technologies, technique, strategies, and we must think about these triples to integrate if we have to combine the solution and to implement the solution. Navigation is also a teacher, really, and it's well known for primary surgery, even for novice and expert surgeons. So navigation really helped me to understand correctly the failures, the mechanical failures of the revision, and helps me to transfer this knowledge for my primary surgeries too. Remember this rule, getting it right first time. It's the team brings concept, and I totally agree, and let's apply this principle to revision. As normally stated for primary surgery, navigation can help us do better. So we can use, I propose you to explore this option. Let's use these tools in our disposal to optimize our practice. Thank you.